We now have 5-minute questions from the members, and I'll start with myself. And I wanted to ask Dr. Schuckett, you mentioned the precautions people can take to protect themselves, but could you elaborate further? And let me just ask, what kinds of symptoms should people be alert to? Naturally people look to their families, and you get all kinds of things. Should I go to a doctor? Should I wear a mask? I'm not you don't necessarily have to comment on that, but what are the symptoms that they should be alert to? And what about going to a doctor? Does it make sense to go to a doctor? Or only certain circumstances? We don't overwhelm the doctor's offices either.
The symptoms of this new strain of influenza virus are similar to the symptoms of seasonal influenza, and they include high fever, body aches, cough, sore throat, those sorts of things. Unfortunately, the symptoms of influenza are very nonspecific, and they can be caused by lots of other things. It's important for people to use judgment. If you're really sick, you need to make sure you consult your healthcare provider. And if your children are ill, the same thing. But it's also important to recognize that this is a time where we don't want the worried well flooding the emergency rooms. We really do need to be careful about that kind of thing. One of the emphasis areas has been diagnostic tests to help us differentiate this new virus from other illness. And so we're very pleased that this emergency use authorization went forward, and the states are now prepared to differentiate this new flu virus from other things. But in general, mild illness, you really are able to stay home and self-care, and illness that's a little bit more severe, you want to make sure you contact your healthcare provider. In particular, in areas where there hasn't been any recognized disease yet, we want people to let their healthcare provider know if they have these sorts of symptoms and have traveled to one of the areas that's affected.
Well, you mentioned Mexico. I mean, I do see. Well, people mention Mexico. Obviously, I do see on TV, people in Mexico wearing masks. I mean, that doesn't make. I mean, maybe it does in Mexico, but here, that's a little severe, isn't it?
We think there are a variety of interventions that'll help reduce the risk of respiratory infections, and we do feel for the people in Mexico who are in a difficult circumstance now and really doing everything they can think of to try to protect themselves. Here we have issued guidance for the mask use for different circumstances, and we update our guidance as we get new information on our website. But I think it's important to say that guidance is going to be different in different areas. The New York City area was having an outbreak in a school that was fairly large, and their guidance was really targeted at the circumstances on the ground. CDC is trying to issue guidance and updated guidance very frequently for the country, but we recognize that the local authorities have the best information on their circumstances, and we really want people to know what's going on in your own community, what do your local authorities say, and really use us as a technical support to those local entities.
Okay. Let me ask Dr. Sharfstein about the vaccination. I mean, I seem to recall, I don't know if it was at the briefing yesterday or that they said that, probably wouldn't be available for everyone until maybe November at the earliest, possibly not till January. I remember in 2004 when we had a major shortage of the seasonal flu vaccine, and at the time the public health officials were saying that if we faced a pandemic we wouldn't have adequate vaccine capacity. Can you explain what the government has done to increase the vaccine manufacturing capacity? And where are we now? I mentioned that, I don't know where I heard that November to January. It might have been at the briefing we had yesterday, but
sure.
If you would comment on it.
I'm happy to answer that. 2004, there were only about 60 million doses of vaccine for the flu that year because of the problem that one of the manufacturers had. And in addition, the infrastructure was relatively weak, and there wasn't the capacity if there was a pandemic to be making another vaccine. But because of the committee's efforts and the federal government's efforts and FDA's efforts, there's been a tremendous shift since that time. I'll go through a couple issues. One is that there was funding appropriated to strengthen the vaccine infrastructure, and one way to talk about that is eggs. Flu vaccine is made in eggs, and in 2004 there weren't extra eggs. There was just the eggs for the regular flu vaccine. But HHS has gone out and contracted. They have extra flocks, and we've gone to a year-round egg availability. So there isn't any months where eggs aren't available. So that reduces most of the time that people were worried about in 2004 would be the delay. On FDA's side, FDA aggressively went out and solicited other companies to be making the flu vaccine for the U.S. market and use an accelerated approval approach to bring online 3 new manufacturers. So this year, I think the capacity is around 130 or 140 million doses instead of just 60 in 2004, with additional manufacturing capacity potentially out there, and all the companies already engaged with us on how to make the vaccine and the eggs available. I was hearing that we now have the capacity where we had 200,000 eggs a day only during the flu vaccine season, that has gone up considerably, maybe as much as 500,000 eggs a day year-round. So right now, the capacity in the system and the ability of the manufacturers to make vaccine is so much better than 2004. The challenge is, and why people are talking about different dates to when it could become available, has to do more with the virus than anything else. There are several steps to make a vaccine and test a vaccine, and each of those has its own uncertainties. If everything goes extremely well, we'll all be happy, but we don't know if everything will go extremely well. You could have a problem creating the virus initially, a problem growing the virus. Then when you make the vaccine, you have to test it to see whether it generates the immune response you're looking for, or else it may have to be reformulated. So I think that the position is, to explain, is that the infrastructure we're building on is extremely strong, particularly compared to where we were in 2004, but we're dealing with an unknown virus, one that hasn't been turned into a vaccine before, and there's a lot of uncertainty about how that will go. But it's really a scientific uncertainty. I think the basic infrastructure to succeed is there. Okay,
thank you. Mr. Deal?
Dr. Van der Wagen, first of all, I'd like to ask you, how did the administration arrive at the $1.5 billion as the figure that the request is made for? How would that money be distributed to which agencies? What would those agencies be allowed to use that money for? And are there other funds that HHS can currently draw on to deal with this matter?
Thank you, Mr. Deal. Good question. When we analyze the potential demand for additional antivirals, we look at the cost of production of vaccine, we look at the cost of potential medical supplies should we have a wider, more severe event in the medical environment. When we look at a number of those issues, the cost requirements can be fairly significant. I think the President's intent was, given that there are all those potential uses, depending upon how this thing progresses, that this was a place to start. I think the majority of that would be looking at such things as additional medications, additional development associated with the vaccine and getting it to the point where we have a safe and effective vaccine, and providing some support to local and state requirements for preparedness. I think those are the kinds of issues that we're looking at in terms of where that that funding would go. And I can tell you...
You're not allowed to cough during this hearing.
Pardon me?
I'm joking. You're not allowed to cough during this hearing.
Oh, yeah. Well, it's allergies in my case, not...
I got your problems.
So the universe of need could be quite large, much larger than that figure, in fact. But this is a way for us to look at some of the known things that we think we're going to need to take care of. We are currently replenishing our stockpile for those amounts. We're considering that. We have funds inside the department we might be able to use to cover that. So that's a decision point that we're examining right now. If we want to cover those antivirals that we've already sent to the states and replenish that, we may have funding available to us internally to do that. But beyond that, if we're going to start talking about wider support to antivirals, it will be a very difficult challenge to find funding within the existing HHS appropriations for that.
So part of it would go to facilitate FDA's more rapid response to approving vaccines, for example, for this particular thing? That's part of what I hear you say. Is that right?
Well, the short answer is yes. NIH will conduct clinical studies for safety and efficacy in partnership with FDA. That takes funding support. We would be looking at beginning to develop the pilot lots. That costs money to do that particular clinical trial. In series, we'd be looking to try and ramp up vaccine commercial production capacity while those tests are undertaken. Those all have costs associated with them.
All right. Dr. Sharfstein, from the FDA point of view, I've been told, and I think the chairman alluded to this as well, that if we are developing a vaccine specifically for the H1N1 virus, that it could be done as a separate vaccine for that, and I've been told it would take maybe 4 months to get that from the time you arrive at what you think the formula needs to be, about 4 months to get it to the production stage. Is that generally about right?
I think, first of all, let me just to follow up on what you said before. There may be extra funds FDA needs, but I want to assure you that everything we think needs to be done is being done, and the management structure we have in place is really pushing, the staff, and everybody is completely committed to doing everything we need to do to meet these different goals on each team as quickly as possible. 4 months is one possible scenario, but what really depends on is how this virus behaves in a vaccine. And I'll just give you an example. We've got to combine it with other viruses in order to get it to grow fast enough. Then it's got to eventually be grown in bulk, and then it's got to be tested in people to see how much of it produces an immune response. If you do the first test and it doesn't show the right, and it may be the first test has a couple different options, but based on that data, you have to look at it because our goal is both an effective vaccine and a safe vaccine. Okay. So it's gonna depend. We're not going to be waiting for eggs. That was actually one of the biggest problems in 2004. And
I hate to interrupt you, but my time's about out. I want to ask you one other thing. My understanding is that each year in the seasonal vaccines, that you choose up to maybe 3 different strains. I assume this was not one of the strains that was anticipated to be included in the seasonal vaccines simply because you didn't, first of all, anticipate it, secondly, had not had the time to ramp up for it. Are you so far along, I assume, in the seasonal vaccine process that if you were to be able to come up with a vaccine for this, that it would not be allowed to be included in the seasonal vaccines but would have to be a separate vaccination program? Is that a correct assumption?
Well, that's an excellent question. You're right that it was not in the flu vaccine that had been prepared because people weren't aware of the virus's existence. And right now we're basically developing with the manufacturers the ability to make a vaccine, and then there has to be some strategic decisions made over the next few weeks. One of those decisions is going to be whether to make this as a standalone vaccine, to combine it with other vaccines, and that in part has to do with the manufacturing capacity. If you make a single standalone vaccine, you can make more of it. So, and in part that's going to depend on how much of it you need to develop the immune response. So there are a lot of factors out there, and what FDA does is it works with CDC, the World Health Organization, and an advisory committee of experts to look at all the evidence, look at what we know about how this vaccine looks to us, as well as what we know about the manufacturing capacity, and then there'll be a recommendation about how this integrates with the seasonal flu. So it might, it's too early right now to have an answer, but it is an excellent question, and I think, probably within a few weeks we'll be able to know more and be able to give a better answer.
Thank you, Mr. Deal. Chairman Waxman.
Thank you, Mr. Chairman. Dr. Schuckett, I'd like to explore with you how this virus is different from other flu viruses. Most people are familiar with the fact that we have an annual vaccine to deal with the flu that might be in the flu season. And we're in the middle of all this where the flu season is pretty much over. Every year, millions become ill. About 36,000 die from the regular seasonal seasonal flu in this country. But this new H1N1 flu does appear to be different. And I still recognize we have a lot to learn, but I'm hoping you can clear up a few questions. Can you explain what the H1N1 flu is and how it's different from the seasonal flu? Is this virus easily transmitted from person to person? And do we know how dangerous this virus is?
Thank you. This is a new virus that humans have not had before. There are H1N1A influenza viruses that we get every year as part of seasonal flu, but this is a new H1N1 strain that we hadn't found before in all of the banks of strains that we've looked at. It's a very unusual one. It has 4 genetic components in it, one that comes from swine from North America, one that comes from swine from Europe and Asia, a third part that has human origins, and a fourth part that has bird origins. So it's a very unusual virus, and we don't believe that humans have experienced it before until these cases that we're seeing. It does appear to be easily transmissible in terms of the information we have already here in the United States as well as in Mexico. But we don't have good information about how dangerous it is. It's a very important issue. In Mexico, we're getting more data about the severity. In the U.S., we are in early days, but really trying to understand how severe it is. We're taking it very seriously.
On the news shows, there's a constant comparison to the pandemic flu in 1918, which did such devastation. And it's worrisome when we hear about this comparison because that virus affected not just the very young and very old, but also affected otherwise healthy adults. Early reports suggest that many of these people who are being hospitalized in Mexico were apparently young and otherwise healthy as well. I know it's early, but can you tell us in what ways this might be similar to 1918?
A worrisome sign from the early reports in Mexico was the age of the patients and the apparent young, healthy adults. That did ring a bell from the circumstances back in 1918. So far, the cases we've had here in the United States that have been laboratory confirmed are relatively young also. I think our median age is 22 right now. But again, we're beginning to collect more information, and these things could change quite a bit. There's some very different circumstances from 1918. Today we have antiviral drugs that treat flu. We also have antibiotics or antibacterial drugs that treat the kinds of secondary bacterial pneumonias that we think played a role in the 1918 devastation. We have better healthcare circumstances. We have much better communication and hopefully more skilled leadership who is doing the communication. One of the really important things in addressing something like this is making sure that people have good information and that our interventions are not worse than the virus itself.
So even if we assume that this virus is as bad as that one in 1918, these modern medical advances will be helpful in treating patients. We're not going to see the same kind of death and terrible results that we saw then when we didn't have vaccines, we didn't have antivirals, we didn't have the whole infrastructure of communication that we now have.
You know, I think that the circumstances are much better today to respond to this kind of thing. I also want to introduce the uncertainty that every new strain is different, and we really need to learn as we go about how this one will behave. We also are mindful of circumstances in other parts of the world which may not be as fortunate as ours.
Yeah. And would this virus possibly mutate during the next several months?
Influenza viruses can mutate frequently, and we need to keep our eye on them. So during the regular seasonal flu, we test strains all throughout the season. Often we find changes in the resistance pattern of the virus. We're very happy that the original viruses, strains that we've tested are sensitive to the Tamiflu and Relenza that's in our stockpile, but we need to keep looking at that. And we also need to look at the antigenic or immune properties because that will feature into what vaccine may be useful. So we are, they do mutate, and we need to keep our eye on that.
Thank you. Thank you, Mr. Chairman.
Thank you, Chairman Waxman. Mr. Gingrey.
Mr. Chairman, thank you. First of all, let me just associate myself with the comment that our Chairman Emeritus, John Dingell, made in his opening remarks in regard to not overreacting to the point that we create a pandemic of panic. And I want to thank our panelists. I think already some comments have been made to that regard. And yesterday when Secretary Sebelius and Napolitano and Dr. Schuckett, you were there as well, it's very reassuring to members of Congress to get the feeling that we indeed are prepared. The remarks that we heard from Dr. Sharfstein, of course, just add to that. I feel good about it. I think what occurred in 2003, 2004 in regard to the fear of avian influenza pandemic led to a $6 billion emergency appropriation, and as you have pointed out, a lot of that money went toward making sure that a stockpile of Tamiflu and Relenza was beefed up to something like 50 million courses, not just one dose, but courses of treatment, and also the 3 or 4 pharmaceutical companies who had maybe been in the domestic business of manufacturing vaccine, but because of liability and no reimbursement for the vaccines that were never given, it was not a very cost-effective business for them. We helped with that, with grants, and some of that money was spent in that way. And then it's my understanding, and this was, of course, what Ranking Member Deal mentioned as far as the $1.5 billion, Dr. Van der Wagen, that $1.3 billion of that original $6 billion is still available. And I want to ask this question about that particular amount of money. President Obama, I think, had no choice because of he doesn't want to get Katrina, the media frenzy about this issue leaves him no choice but to say, well, look, we're not going to go to sleep at the switch and we're going to appropriate this money. But if Dr. Sharfstein, if we decide that it is not really appropriate, not really necessary to go forward with the development of that vaccine specifically against this H1N1 flu, we won't call it swine flu, then maybe at some point when this is all said and done and it turns out to be a mild disease and people kind of go back to their normal living and they're not shutting down schools because one child is sick and they're not avoiding the subways and taking commercial airline flights. I mean, we're getting to the point where I fear that we're getting ourselves in a frenzy, and it's inappropriate. So if this thing turns out not to be the real bad pandemic that everybody fears it could be, then I would hope that the money that's not spent to develop this vaccine will go back to John Q. taxpayer, go back into the general treasury or whatever, and not just stay there and for the next 10 years when it's really not needed. I don't want to underplay this. I'm a physician member. I don't want to have egg on my face a month from now, but I do agree with Chairman Emeritus Dingell that we don't want to overreact here, and I think Dr. Schuckett mentioned that yesterday and again today, and I would like for all of you to comment on that a little bit if you would.
I think it's really important to recognize the uncertainty that we have, that influenza can be very unpredictable, that the evolution of the situation in the past week has had many worrisome aspects, but that we are acting aggressively. And I think that we really do need to make sure that we are able to aggressively respond. An important issue, I think, is that the investments that were made in the past few years for pandemic preparedness have greatly strengthened our response to seasonal influenza. And as was mentioned, 36,000 Americans die every year from seasonal influenza. So it's likely that flexible programming of emergency funds would be flexibly applied to strengthening our work against the seasonal flu, which is such a killer in America.
I think that your point is very well taken, and we heard about the analogy of the 1918 flu, but some people have also been discussing the 1976 swine flu situation, and in looking back on that, some historians have said that might have been an instance where people were overreacted. And the lessons, I think, that were drawn from that experience was that you've got to separate out the preparation for the possible worst-case scenario from actually implementing it. And that people, in looking back, felt like maybe because they had a vaccine, they had to use it. And I think it's very clear now that those two things have got to be separated. It's in the end going to be okay if we have a vaccine, but turns out not to be a pandemic. We just don't want to be in a situation where we have a pandemic and we don't have a vaccine.
And the last comment, just to finish out your threesome here, sir. I think that we are now down to about 600 million remaining. And most of those, as you know, we received special milestone payment authority under the Pandemic and All Hazards Preparedness Act for acquisition of materials and so on. That balance is really already sort of pre-committed as part of those milestone payments, which are going for diagnostics, new antivirals in case we develop resistance to the existing antivirals, and to support some other vaccine analysis that's ongoing. So it's committed in the milestone payments stream for those products that are in development.
Thank you. We just have one vote. I'm going to try to proceed with questions. I'm going to see if there's some way that we can work it out so that we don't have to break. But I don't know if that's possible. But in the meantime, if we'll proceed to Chairman Dingell.
Thank you for your courtesy, and I commend you for the hearing. I have several questions I'd like to have for the record, and I would ask unanimous consent that the responses be inserted into the record at the appropriate place and fashion. The first one, who is going to be the lead agency? Is it going to be HHS, or is it going to be the Department of Homeland Security?
The simple answer is for public health and medical activities, it's Health and Human Services. For the wider response, if it involves energy, transportation, security, etc., that's all in the hands of DHS. We all work as a coherent team under their leadership.
Do you have a memorandum of understanding defining how that's going to be done?
Yes, sir. There's the National Response Framework with a very specific set of requirements.
Would you please submit that for the record? How is this budget going to be expended? Would you submit to us a statement of how the money is going to be expended, if you please? Now, the states are going to have very severe problem. My home state of Michigan has a budget deficit which has been announced is going to go to $1 billion after some very savage efforts to cut back on the expenditures. How much of this money, this $1.5 billion, is going to go to the states to be expended through their agencies for what purposes?
You know, I think these matters are being evaluated, and the Office of Management and Budget is intending to submit something soon with those types of allocations.
So the answer is we don't know. And I'm assuming that the answer is that you do not yet have a defined budget structure. There's no nod button on the reporter's response. The answer is yes. Is that right? All right. Now, what is the potential for this flu outbreak to reach pandemic levels?
You know, the World Health Organization elevated the phase yesterday to phase 5, which is the second highest phase. But here in the United States, we've already been acting as if it were a full-blown pandemic in terms of our response, aggressively preparing for widespread disease in many communities. We don't know if that will actually happen, but we are seeing sustained transmission in a few communities. We don't yet have severe illness, but or lots of severe illness, but we fear that we may have additional severe cases as we have with seasonal flu.
I would like to have you submit to the committee as soon as you can what assistance the federal government is going to be providing state and local units of government to enable them to address their responsibilities in this matter of flu. And I ask unanimous consent that that be inserted into the record at the appropriate place. I note that FDA is currently using 3 products whose use is being vigorously monitored. The Secretary was granted emergency use under the 2004 Project BioShield law to clear the unapproved use of particular products in the event of an emergency. The Secretary is exercising this authority for 2 drug products and 1 diagnostic test. What are the considerations in deciding to clear the products for use of young children and adults? This is Dr. Sharfstein.
Thank you for the question. The basic considerations are set out in the law, and then I'll tell you how we applied it in this case. That, first of all, there's a serious or life-threatening condition. We know that's the case. Second, that the totality of the scientific evidence makes it reasonable to believe that the product may be effective. Third, that there's the known and potential benefits of the use outweigh the known and potential risks. And fourth, there's no adequate, approved, and available alternative. Now, for kids, the only thing that is done differently under the emergency use authorizations is for Tamiflu, where it permits the use under age 1. And it's an excellent question, because you think, well, how did FDA decide that that was okay? How did you figure out a dose? It was not in the original label. And it turns out that FDA has been looking at this for a couple years and has been working very closely with NIH and the company to get data on under age 1. And there was actually a study that was done. FDA reviewed the study, and even over the weekend got additional data from the company involving more than 750 infants from Japan, and also some German data. There was a study that was organized out of NIH, which was specifically targeted for kids under age.
Please submit the rest of your question for the answer, or rather for the record. I would like to know if your agency has a regular on-the-shelf plan to address these kinds of problems when they arise. Yes or no?
Mr. Chairman Dingell, if I could just interrupt and tell the members, what we're going to do is continue, because of the time constraints of our public health witnesses here. And Ms. Capps, who's our vice chair, is going to come back and replace me so I can go vote. So you will have about 8 minutes left. If you want to leave now and come back, I don't mean the witnesses, I'm talking about the members.
Right.
We're just going to continue. I apologize for interrupting, Mr. Chairman.
I'll repeat the question. I would appreciate for you submitting for the record, 1, the answer, do you have an on-the-shelf plan? You're nodding yes?
Yes is the answer.
All right.
Yes, all of us do.
All right. All 3 of you?
Yes.
All right. And does that include working with the Department of Homeland Security?
Yes.
And do they have one?
Yes.
All right. Would you submit those plans to us for the record, please?
Can do.
Mr. Chairman, I thank you.
Next is Mr. Murphy.
Thank you, Mr. Chairman. I want to thank all the distinguished panelists. I'm learning a great deal here. I'm not a physician. I'm a psychologist, and I understand panic. And I need to ask you some questions, and I'm not meaning to embarrass anyone, but I think it's very important you get some official statements out for this. Is anyone from any of your departments recommending that any American citizens avoid airplanes, buses, elevators, confined spaces? Or do you think that perhaps we should not be saying that right now?
We are recommending that people defer non-essential travel to Mexico. We're recommending that people who are sick not get on airplanes or public transportation, and I think there may have been a misstatement.
Would you all agree with that? We'll let it stand at that. But I do think it's important we let people know this is every year when there is a flu in this country, many people die, sadly, from that. But the main thing is to understand that you're working this issue very, very hard, and I appreciate what you're doing. However, it is a concern about any time people will use transportation, and I'm wondering, as part of your plan, we have the transportation security system set up. Every airport has lots of posters on lots of issues, and I'm wondering, as it says, if you're recommending people not travel if they're sick, stay home if they're sick, if the airports are a particularly important area because that's where you have people who may be ill traveling across the country and spreading this. Is this part of your plan to also include that as a location for other public information posters, perhaps at airports? And added to that, anything you're advising airlines with regard to if they see passengers come to the airport that appear to be sick?
Yes, we've been issuing both guidance as well as developing materials. We've also started to hand out the yellow cards, the travel health alert notices at airports and other ports for people who are traveling to know what signs to look for and what to do if they do become ill. And we're certainly we actually just recently issued guidance for airline crews if they were caring for someone who was ill, what are the steps they need to take. And we'll continue to update those kinds of guidances.
Will this include information that airport security, airport or airline workers, if they see someone who appears to be ill before they get on a plane, perhaps tell them not to fly?
Yeah, that's right. We actually do already have quite a bit of intervention in terms of education for the travel workers, the Customs and Border Protection personnel, as well as a good relationship with the airline industry. We developed a greater collaboration during the SARS problem to really be able to make sure people working in that profession could recognize issues and address them.
And one other thing, and open up to other comments as well. Certainly, we are aware of those things that our parents taught us. You cover your mouth if you sneeze. If you're sick, you stay home. You wash your hands. I see you have your little bottle there. You've been using that very effectively, Doctor. But are there things you advise people not to do? For example, should people go out and get Tamiflu and just start taking it? Should people start taking other antibiotics if they have some in their medicine cabinet? What kind of things are not a good idea for people to do? I wonder if you could comment on that.
You know, at this point, we're recommending that drugs like Tamiflu, which is an anti-flu viral or an antiviral drug against the flu, or antibiotics against bacterial infections, be taken under a doctor's advice.
Are antibiotics useful at all with the flu?
Influenza is a viral infection, and antibiotics treat bacterial infections. Some people suffering influenza can later develop a secondary or late onset pneumonia caused by a bacteria. So there are circumstances late on following influenza where antibiotic treatment might be necessary, but this would all be under a doctor's advice.
Again, I'm asking the panel in this that some people may call in their doctor now and saying, can you give me a prescription for antibiotics? I've got some in my medicine cabinet. I was sick last year. Should I start taking them? What would you all advise? Prophylactic.
We would advise people to not self-medicate, that they should seek consultation with their physician before they take any medical intervention. And we're advising them that this is a doctor-patient relationship that has to be worked through rather than just arbitrarily deciding to medicate yourself.
You agree with that too, Doctor? Thank you. I appreciate that. It is important that I don't want people to take this too lightly nor too seriously. As we've had the SARS issue, as we had the avian influenza issue, these are good, important issues that people need to be addressing, and I do appreciate the important medical common sense information we'd be sending out to Americans. Thank you so much.
I would just add that people can contact their local health departments also to understand what things may be accessible.
Thank you. The chair now recognizes Congressman Green for 5 minutes.
Thank you, Madam Chairman. And again, I want to thank you. I have a district in Houston, a very urban district, and people go back and forth to Mexico literally every day. but I appreciate the measured response, but also the planning, because our governor just announced a disaster declaration because of the issues. We have 2 schools now, public schools, Hamilton Middle School and Harvard Elementary School, because of a child. They've shut down the school, so they're being very cautious, and that's the encouragement. All our districts are planning to do that, I think. One of the concerns I have is that because of the experience a few years ago when we didn't have the development of the regular flu vaccine, and I think Congressman Deal may have mentioned it, you're not recommending slowing the production of the flu vaccine that we know we typically would be receiving in the fall. This would be a separate injection if we get to that point.
Yeah. Right now, there's no recommendation to slow the production. However, as we understand more about the virus, the threat of the new virus, that could potentially change, but it'll be a decision that's made by with a lot of external input from a lot of very smart people thinking about what the best balance is going to be.
Okay. I know HHS is releasing 25% of the strategic reserve of the 50 million treatment courses for antiviral drugs, Tamiflu and Relenza, in the strategic national stockpile. It's my understanding these drugs will be available to all states, prioritizing distribution to the affected states. Is that correct?
Yes, that's right. We've released 11 million of the 44 million doses that were designated for the state or project areas, and all of the states will be receiving those. Already 11 have either received or en route, I think.
I guess my concern is in Texas we're seeing actually pharmacies who are running out because of prescriptions, and I'm glad that's happening. Please,
recall that the principles under which we established that stockpile was a partnership with states, and that the goal was for we in the states to be able to cover 25% of the population for treatment of active disease. That was the principles under which that acquisition was really driven, and most of the states bought their share. There are half dozen states or so that did not, but we're still providing a pro rata share to all the states in that event. But it's about treatment for people who are sick.
Okay. I know Texas has 840,000 7-day courses of antiviral medication, and I've heard we qualify for an additional 650,000. Is that generally correct? Do you know on a state-by-state basis?
You know, I guess actually I just want to correct what I said. What I know is that we've completed the shipments to 9 states, and 6 of the states completed receipt of shipments in the last 24 hours. But we're continuing to work through the listing. So I don't know the doses.
Okay, if you could get that information back to our office. I know Congressman Gonzalez from San Antonio would share the same concern at my colleagues on the Republican side.
There's one thing I might want to mention just to be clear. Like you said that some pharmacies were having shortages. Yeah. And the medicine that's going into the states is going through the public health side, not directly to the pharmacies. Okay. And it's going to be up to the local and state public health plans how that medicine gets distributed.
Well, I guess I benefit. I have a daughter who's an infectious disease fellow at University of Texas Medical Branch, and she told me Galveston, which is not our district, all the pharmacies in Galveston County were out of the prescriptions, but I don't know about in Harris County, which is Houston, whereas Galveston is separate. What role should the state play in the distribution of these drugs? So it's going through the public health like we have, and in fact, that's where I'm getting my information is from the State Health Commission. So,
you know, each of the states has a plan for how they're going to do their distribution. So we look to them to let local folks know how it's going to work. But that has been part of the state's pandemic planning efforts.
In my last 49 seconds, I know you answered the question on the H1N1 vaccine and how quickly we can get a development is a couple of months. 2 months seems a fairly short time frame for a vaccine to both be tested and it's safe for individuals, whereas Tamiflu was recently relabeled to show adverse psychological effects. What precautions does the FDA take to monitor adverse effects from this new vaccine that we're developing now?
Sure. Well, just on Tamiflu, there's a team that's looking specifically at Tamiflu adverse effects. For the flu vaccine, it depends if it's, from the manufacturing standpoint, there's a chance that this will just be produced according to the regular manufacturing approach. in which case, every year it has to be done pretty quickly because every year the flu vaccine is different. Now, if a different approach has to be taken, that will raise different types of oversight issues. But in all those things, assuring that, that the risks are outweighed by the benefits and that we think it's a safe vaccine is really the point of our involvement.
Okay. Thank you, Madam Chair.
Thank you. Ms. Blackburn of Tennessee is recognized for her questions.
I want to again thank you all for your patience for being with us yesterday, Dr. Schuchat, and then for you all being here this morning to help answer these questions. We are concerned. In my district in Tennessee, now have a Williamson County case and a Shelby County case. And so as you can imagine, as this started to make its way into the news last evening and this morning, I'm hearing from parents and from constituents and medical care providers and health care providers with some questions. And one of the questions that has been asked of me, and if you can provide some guidance on how best to answer this, I think it would be helpful. The way we understand the process, when a doctor takes a culture that goes to a state lab, when a state lab suspects that this culture has either the H1 or the N1, and they decide that there is probable cause that it could be the H1N1 strand, that it comes to the CDC for confirmation, then my question is, number one, how many of those cultures do you have waiting for confirmation? And number two, once that culture makes it to you, how long does it take for you to provide that confirmation?
Part of our planning has been to make sure that we have adequate staff day and night for something like this, and the laboratory staff in the influenza division have been we've had shifts throughout the night, throughout the weekend. But we've also taken steps to increase the capacity at the state public health labs with these kits that were recently approved for shipment and started to be shipped on Monday. It was incredibly quick, so that more and more state and local areas will be able to do that confirmatory testing on site. We're not working with a backlog. We're really working around the clock to make sure that information that's so critical for local decision making is available. We're also we've made many contingency plans for the surge idea so that the state and locals have some capacity through the public health laboratory network, and that also we've got some agreements with commercial labs to help with surge of specimens for sort of
Okay, so is it fair to say you all turn this around in a day or a matter of hours? What is the time frame
yes,
there?
there are several steps. A doctor will take a test and may get a positive rapid result or may get a suspicious result, forward that on to the state or local laboratory where the strain needs to grow and additional things happen, although now they have these PCR tests that are more rapid. At that result, things get sent to us. Sometimes the shipping is even one of the longer steps, although we've been really expediting that. And then it's several hours upon receipt in the CDC lab before a result would be available. Things may change over the days ahead as increasing numbers of cases are detected, and we really need to make some triage decisions. But at this point, with new states wondering, do we have this or not, we're really prioritizing that kind of question that is, going to make a difference for a school district, for instance.
Dr. Sharfstein?
Sure, and just to follow on, CDC just did an unbelievable job basically inventing a lab test for this that could be shared with the states within, a couple days. And FDA worked with them so that all the instructions were there, all the quality assurance procedures are there. And now the State Public Health Lab Network, which was sort of created to be ready for exactly that, they have the kit. So for someone in your county, really it should go to the state lab, and they're the ones making the diagnosis. Those samples shouldn't even have to go to CDC anymore. And that was all done so quickly to be able to give them that capacity.
That is great. So individuals should know within a day, 2 days. What would be the answer?
That probably is going to depend on the policies of the state
Of the
lab.
state.
Yeah.
Okay.
But the test itself doesn't take more than a few hours. It's a question of how they're handling getting
All right. And
samples.
you have both the public labs and the private labs involved in this process.
It wouldn't be the hospital labs. The public state labs or some of the bigger city labs are part of this public lab network. There are a couple commercial laboratories that aren't doing that special testing, but they're ready for surge of the original testing.
I've got one other question, and we may not have time for you to answer it, but we've had questions from several people. This is not flu season in the U.S., and this seems to be a very strong strand. And as we move into the warmer months, it may naturally dissipate, but your expectation for when we move into flu season in November, how do we best prepare for a resurgence? Do you think it will come back? Will we have a vaccine by that time? What is the preparation strategy for next year's flu season?
These are really important issues. We are mindful that things may look like they're getting better, but we might have a resurgence in the fall. There are many steps being taken to anticipate that, and part of the efforts of evaluating production of a vaccine is with that in mind. Also looking to the Southern Hemisphere for what happens there, because they typically have a reverse season from us, and then also understanding the evolution of the virus during the next bit of time. While flu season is pretty much over in most communities here in the U.S., it's not completely over everywhere, but you're right that we usually don't see cases in the summer except in people coming back from the Southern Hemisphere, and then we will be mindful in the fall.
And I would say we would like to have a vaccine as soon as we can get one, and even if let's say you have a vaccine and it doesn't come back in the fall, that's okay. What we don't want to be in a situation is you have a serious problem and you've stopped making the vaccine for some reason. So the plan is to prepare for the worst.
Thank you so much. Thank you, Madam Chairman.
Thank you. The chair now recognizes the vice chair of the full committee, Ms. Leggett, for questions.
Thank you, Madam Chair. I want to congratulate all of you and your agencies for the aggressive efforts and smooth preparations you're taking here. I've been on this committee now for 12 years and remember quite well the hearings that we had in 1993, 94, and 95. In fact, I've been urging our leadership to have additional hearings and so that we could see the progress, and I'm gratified to hear that we have made progress. I do have a few questions, though, about what will happen. My first question is, do we have a sense of what the incubation period of this virus is?
You know, we're looking at these new cases and the numbers change day to day. Recently, I would say conservatively 2 to 5 days or maybe 1 to 5 days. The idea is that it's a relatively rapid transmission from one person to another.
One thing I think is that you know, I have a high school freshman in Denver, and I think at high schools and colleges all around the country, many of the students are concerned that if they or someone they knew went to Mexico some weeks ago, that could still be incubating. I think that's important to say, although of course it can be transmitted from person to person here. My second question is, I'm concerned about the fact that while we've come a long way over the last few years, as Dr. Sharfstein was describing about developing the egg-based vaccines, I'm concerned that we still have not been able to move to a cell-based production, and I'm wondering if you can talk about what the status is of development of a cell-based vaccine.
Sure. There's been a tremendous investment in cell-based technology, and so that was done in parallel with getting the eggs up, capacity up, so that the egg-based vaccine could be produced relatively quickly. There are companies that make cell-based vaccines, and FDA is working very closely with them.
Are you working closely with them to develop cell-based vaccines around this new H1N1 virus?
You know, yes, in the sense that we're discussing that with them, but I think that the sense that I'm getting is that because we have a licensed process for the egg vaccine and because we have the eggs, that we have a terrific potential capacity to make plenty of vaccine with the traditional approach rather than have to, and that would be our preference because we know all the steps in the process.
Well, except for the fact, Doctor, that if it truly does turn into a pandemic, then having 160 million doses by next January or whenever is not going to be sufficient even for the U.S. population, much less around the world. And so it's great in the short term, but ultimately we're going to need to move to that cell-based vaccine.
Your point's very well taken. I think a couple things to say. That's why we're having the conversations with them, and that is the future, and that's why there's such an investment.
But it's not going to be the future for this particular strain, correct?
I wouldn't rule that out. I think that's under discussion, but I think that what I've heard from the vaccine team is that they believe that there's a tremendous potential, and it's probably the potential is larger than 160 million doses. That 160 million doses are trivalent vaccine, so meaning that 3 strains.
Okay,
so it's actually probably somewhere around triple that. And
okay,
plus
but efforts are being made to move to the cell vaccine.
Absolutely.
Even with this. My
Correct.
next question is there some potential that this this virus could mutate in the summer months between now and the fall when we think we might see a resurgence? Dr. Shukat?
Yes, that is possible, and that's why we'll be continuing to look at it. Just to clarify, the planning assumptions were to have capacity to be able to produce enough vaccine for 300 million people, assuming 2 doses. And there are lots of things to be sorted out about how much quantity we're going to need that will influence what the real capacity is.
Right. But again, I'm concerned because if with this old egg-based technology, which, like I say, I think we've come a long way. I'm not trying to be critical, but if, heaven forbid, the virus mutates between now and the fall, then we have to develop a new vaccine and keep with the egg-based technology. We may not have a vaccine developed until next spring, and I think that's worrisome to all of us. Dr. Vanderweg?
Ma'am, let me add 1 or 2 things to what Dr. Sharfstein has offered you. One is we think 600 million doses is achievable in a 6-month time frame. We think that's achievable both in egg-based with some cell-based augmentation. Part of Congress's investment, all the money that was talked about in flu investments, $1.3 billion went to the development of cell-based culture.
I know.
We have 2 large plants that are very late stage of construction. They're close to inspection, and we've made significant progress with them. Will they be ready by January? I don't know that they will exactly be ready by January, but we know from the existing infrastructure we could probably generate a monovalent 600 million doses in a 6-month time frame.
Thank you. Mr. Chairman, I would hope that these witnesses and their agencies would continue to keep this committee apprised of their development of the cell-based vaccines and their development of the doses as we move forward in the coming months.
I'd appreciate that, and I'm sure you will.
Thank you, Mr. Chairman.
Thank you. Our Vice Chair, Ms. Capps.
Thank you, Mr. Chairman, and thanks to each of you. You've been spending a lot of time the last couple of days here on Capitol Hill, and it's very valuable for us to have your expertise and to be kept abreast of what's going on. A different set of questions from me, please. The recommendation for people, and I'll address this to you, Dr. Vanderweg, and all of you have comment, but I want to just sort of go from topic to topic. I have 3. The recommendation is if you have the symptoms, call your health provider. 47 million Americans don't have regular access to health care. It seems likely that if this progresses and becomes worse, emergency rooms and hospitals, other public places are going to be on the front line of receiving all of these patients, because they would be the first place, the only place many people could turn. Our emergency rooms are already overflowing, and it's clear that responding to a pandemic would be more than they could handle under existing circumstances. Our goal now, simultaneously, is to work toward providing health care for all Americans, access to health care. In the meantime, I want to comment from you on what kind of emergency coverage, or do you recommend a particular plan that we could speedily enact to provide coverage, or in this case of an emergency?
Well, Madam, I really appreciate your linkage between preparedness and health security and health reform, because I think those are they are intertwined in a way that people don't always realize, and I appreciate that. Medical surge is a function of people, facilities, supplies, equipment, and systems. And what we've seen with investments that Congress has appropriated to us in hospital preparedness is the emergence of systems that rely on the fact that no one place is going to be able to manage the flow. So how do we work collectively to share that flow in a way that takes the burden off? We've seen extraordinarily good examples of this in a wide variety of states: Illinois, Minnesota, North Carolina, etc. These are best practices that have been put in place that these states have already done a significant job of analyzing people, equipment, facilities. Those are the kind of best practices we would extend to communities that are still trying to find the answer to that problem. The emergency management assistance compacts between states also offers us ways for hospital care, not so much emergency department evaluation, but for hospital care. There are good models out there and best practices that we can share with communities.
Thank you. And Mr. Chairman, I would hope that we could keep this discussion going as the days go, in case there's a way that we should be responsive to you as well. Right. And now another challenge, Dr. Shukat, for the provider in the household. You are calling on people to stay home if they're ill. To prevent the spread of the H1N1 flu, but millions of people work every day but don't have any sick leave, don't have any time that they can take, and with this economic uncertainty, they're very reluctant to stay home from work and may go to work with symptoms or have to send their kids to school because there's no one to stay at home. This is going to be difficult to contain the flu. We do have legislation in the works, Senator Kennedy and Congresswoman DeLauro planning to reintroduce the Healthy Families Act. I'm co-sponsoring it, but that would guarantee 7 sick days a year. First of all, you could help us with support of that kind of legislation for the next event, and maybe if you have any thoughts of what you or we could do together to respond to this crisis.
You know, just a few comments. Health in the workplace and health in the family is very important. It's a central component of public health. And we did see during the SARS epidemic that in Canada, some of the hospitals were really taxed trying to figure out how to make sure that healthcare workers, including contract employees, would stay home, whether furloughs needed to be used. And it was a very difficult circumstance to make sure that health was taking a front seat and that the right. rules could be worked out. So we would just be supportive in making sure that health is addressed.
Thank you. I have one final question. There's not a lot of time for it, and maybe some ongoing conversation about this is to either any of you, because workforce shortages are something that you are experiencing in every of your agencies and of all of our local and state public health facilities. 11,000 public health workers are due to be laid off because of state budget cuts, attrition over the past year. This is exactly who you are depending on even as we speak for solutions. Do you recommend any suggestions for us to help you do this or to recruit more or to implement anything?
Well, a month ago I was the local health officer in Baltimore, Maryland, working with Congressman Sarbanes and others. And I think your point is very well taken, that a lot of the things that are being planned at the federal level really depend on the state and local public health authorities to implement. The emergency use authorizations that we granted give a lot of have a very clear role for state and local in how they hand out medicines that may be important to people. Eventually, if there's a vaccine, that's going to be delivered through the public health infrastructure, and ensuring that that infrastructure is strong is extremely important, and I know is very important to the administration.
My time is up, but there's more to talk about. Thank you very much, Mr. Chairman.
Thank you. Mr. Blunt.
Mr. Chairman, I have a couple of questions here. One, I got a email from my daughter late last night who lives in Kansas City, and it involves her, but it even more importantly, and just as importantly, involves my grandchildren. I guess I ought to think about how I say that. And the email from her is confirmed case of swine flu in Kansas City. On a scale of 1 to 10, how concerned should we be? Anybody want to give an answer to that?
Yeah. You know, people like your daughter are concerned, and so are we at CDC, and so is the government. But we're taking aggressive steps to address the challenges, and we do feel that we have been exercising and planning for this kind of circumstance. There's lots of things everybody can do in the community, in the family. as well as in schools and workplaces. And so I think that this is a serious situation, and we all really need to get ready for some uncertainty, to stay aware. It's great that your daughter knows exactly what's going on where she is, and that guidance from the local and state authorities will probably help her understand what's going on there and what the next steps are if your grandchildren's school is closed, for instance, or really what are the plans?
What about, it's called swine flu, but is there any concern about the food supply at all? I mean, I think it's important to clarify that, and you may have already, but if you wouldn't mind repeating that for me.
Sure. There's no evidence that swine in the United States have this new virus. There's no evidence that eating pork or pork products gives you this infection. The USDA is aggressively looking at the issue both here and working with Mexico as well. And I would say that we don't have any reason to believe that eating pork gives you this particular infection.
And we have no reason to believe there's any other problem in any part of the U.S. food supply.
No, this isn't an infection that we think is foodborne.
Our veterinarian colleagues over at agriculture call this human flu because it doesn't occur. They don't see it in pigs, so they're calling it human flu.
I think that's a good thing to understand, because I think there is some reaction at the grocery store to what they think. The other question I'd have on Amy Blunt's scale of 1 to 10. Assuming 10 is the most concerned, it seemed to me that the vice president was there this morning at the 10 level when he said he'd advise people not to get on planes, his own family, or even on subways. I'm sure that's not the official position of the government. Would somebody reiterate what must be, for a repetitive response, the official position of the government on that topic?
We've advised people to defer non-essential travel to Mexico. We've advised people who are ill with respiratory symptoms and fever to not go to work or school and not get on an airplane or public transport. But we do not have recommendations to stay away from those transport methods if you don't have respiratory symptoms. And I'm looking forward to getting on an airplane later today to go back to Atlanta.
Well, most of us will get on airplanes later today too, and go back to Atlanta or Missouri, as I will, or other places. And I would hope that the commerce and the travel of the country don't shut down based on advice from the government. I yield back, Mr. Chairman.
Thank you, Mr. Blunt. Mr. Wiener.
Thank you, Mr. Chairman. Let me just pick up on that a little bit. I think you'll forgive our constituents for being a little whipsawed by the news and images that they get. And I represent the district that has half of all of the confirmed cases in the country. And, to watch some of the imagery on television, to listen to even official channels, to listen to the head of the health policy at the European Commission, in theory someone who's supposed to be pretty level-headed, say it's not a question of whether people will die, but more a question of how many. Will it be hundreds, thousands, or tens of thousands? You'll forgive some of my constituents for wanting to get into the fetal position and bathe in Purell after hearing things like that. And let me say that it is in contrast to the way you all have presented yourselves, and so too with the health officials in New York City, who I think have made a more sober assessment. But just to put a finer point on the question Mr. Blunt asked, focusing on subways, to instruct New Yorkers to avoid the subways is to, in many cases, instruct them not to make a living, not to travel around their hometown. It is the very way that we communicate with one another and the way we get to and from. If you are not one of the 96 confirmed cases, if you don't feel like you've got the flu, can you just say with clarity about subways, it is safe to get on a subway, we would encourage you to get on a subway, and if there was a subway to Atlanta, you'd take it?
The only people we're saying should avoid crowded circumstances or airplanes, for instance, are people with fever and respiratory symptoms. We also think it's important for local authorities to be the giving the guidance for the community. They understand the way the ground truth, and we know that the New York City Health Department is fantastic and really is providing good guidance.
Can I ask you, how good a job did the Mexicans do on letting you know what was going on? It's a report in today's Washington Post that lays out the tick-tock of notification that seems clear that the 24-hour rule was violated by a magnitude of a couple of weeks. Apparently, our Department of Health and Human Services, which oversees the CDC, found out about the Mexican outbreak about the same time the rest of us did on television on the 24th. It strikes me that that window of time is valuable, and it strikes me that, in fact, it could have helped, well, maybe prevent some, or at least gotten us a couple of weeks or a few days at least jump on this. How would you grade the Mexican response up to now?
The Mexican community and government are coping with a very difficult circumstance right now, and the focus of our attention is providing technical support to help them respond to the situation. I can say that I don't have all the information. I don't think anyone does yet about all the circumstances leading up to where we are. But it's important to note that increases in respiratory illness happen quite frequently, and they can have lots of different explanations. And as I understand it, the original increases that they were seeing were believed to be due to regular influenza. Most respiratory infections don't actually get a specific diagnosis, and we see lots of changes in the numbers that don't pan out to be anything quite serious. Here in the U.S., because of our investments, we promptly recognized these very unusual strains of influenza and issued a MMWR dispatch after the first two that we had seen. But I think the circumstances in Mexico right now, the focus really needs to be on helping with the response.
Can I say, it is traditionally the influenza outbreak happened in cold weather. And I know that there's some disagreement in the medical community about why exactly it is. Maybe we're all together much more. Are we rooting for a particularly hot stretch here? Would that help us? Should we be trying to be out of doors more? I mean, is the coming summer months, is it helpful to us? Is it not clear that it's helpful? I mean, if there's a high pollen count, does that mean that perhaps we should be more careful? Are there any weather-related indicators, since this is kind of a counterintuitive strain, it's hitting younger people more? Are there things about it that we have learned so far that gives us an indication that the weather might be on our side here?
We think from the past and from seasonal flu that we don't see much influenza in the summer months, and so we hope that will be the case. But every influenza expert that I hear from really cautions me in anything I say to remind people how unpredictable influenza can be, and especially a new strain. So we do optimistically hope that things will get better because of the season, but we need to be attentive for the fall afterwards.
Thank you. Thank you, Mr. Chairman.
I would just say that if we can get time, that really helps with the vaccine production. And the point about the how each virus is different is extremely important about vaccine production. And I think, just to clarify, I think the idea that a certain amount of vaccine will be ready in a certain amount of time, those predictions really can't be made now until we understand more about this particular vaccine, this virus.
Thank you. Next is the gentleman from Maryland, Mr. Sarbanes.
Thank you, Mr. Chairman. First, I want to say how impressed I am with the response that you and your staff has made to this situation. There's been a calmness and professionalism to it that I think is having the desired and appropriate effect on the public, and I know that will continue, so thank you for that. I also want to echo those who are welcoming Dr. Sharfstein to his new position. As he indicated, we have worked together closely in Baltimore. We've suffered a great loss that he's now here, but the country is certainly gaining by his appointment. Dr. Schuckett, you mentioned, and I was intrigued by this, that the number of cases is not something you're so much interested in as the patterns that you see emerging. And I wondered if you could describe a little bit more what you mean by that. What are the patterns that you're looking for, and what do those patterns tell you about the progress of this disease?
You know, we're working closely with some of the state and local public health officials who are on the front line of responding to this to really understand the epidemiology, who's more likely to become ill, what are the clinical characteristics of illness, how does it look like the infection is spreading, and how transmissible is it? So those are things we're evaluating in some of the on-the-ground circumstances in the U.S. as well as with our Mexican and Canadian partners. Those types of investigations can help us understand what kinds of interventions will be most effective. We would love those investigations to show us that disease is becoming milder, but we need to be ready for the idea that the disease is becoming more severe. So rather than focus too much on individual numbers, we know that numbers are going to be varying, that information is in flux, that we've just decided at the CDC once a day we'll update the numbers, and we're really focusing on the actions and activities. And so the patterns are really at an early phase understanding which populations are at the greatest risk, how transmissible is the virus, and then that severity.
Is it a combination of the patterns and the numbers that would also advise as to when a community ought to be taking particular action, shutting the schools in a community and so forth?
Right, that's right. We have guidance about when there's illness in a confirmed illness in a school, that we recommend that school be closed temporarily while things are being reevaluated. But there could be triggers that would prompt a more aggressive approach beyond that. There are other community interventions such as eliminating mass gatherings or really implementing social distancing, asking people to work from home and to really avoid crowds. I was in Beijing during the SARS epidemic, and they intensively instituted those, and they really helped, but that was a very different circumstance. So I think the pattern will tell us whether more aggressive measures are needed. We're really trying to strike a balance and making sure the interventions are not worse than the virus, because there's a balance in all of these interventions.
Let me ask you a different question. There's been a lot of discussion and focus on sort of tracing back this virus to a specific geographic origin. Is that the right perspective to have? I mean, is it the case that that this disease will be appearing, as it were, spontaneously in a number of different locations, or does it make? Because when I hear people discuss they've found new cases, then the next question always is, did you have contact with somebody who recently traveled too? But that can't be the only dimension of the inquiry, right?
Yes, that's right. I think in the initial days there was an intense focus on contact with animals, and then a little bit after there, contact with Mexico. We're at a different point where there are lots of exposures that are being looked at, and really the intense look for cases is so that interventions around those cases and where they work or at school can be imposed. So for those other sectors that are focusing on, tracing back and where did this all start, that can be important information for future planning. But I think the public health community here in the United States is really focusing on what we can do to reduce illness and death and slow spread, giving time for more definitive interventions like vaccines should we go that route. And really taking the focus of our goal is to reduce illness and slow transmission, not to find the source.
Right. Mr. Chairman, can I ask Dr. Sharfstein to be a 15-second question?
Sure.
Okay, I appreciate it. My understanding is that the flu strains we experienced this past winter did not respond particularly well to Tamiflu. Is that correct?
Yes.
Okay, but that we're seeing that at least initially this strain is responding. So I guess that's a lucky thing in a sense, right? Because it could very well be that this strain also would not be responding. And so I'm just putting that in the happy coincidence category. Is that fair to do?
Yes, but
Okay.
there are always a few qualifiers. We know, I think, looking at it genetically and in the lab, that it looks like there's activity against the virus. That doesn't necessarily mean that every patient, as soon as they get it, gets better. In fact, it's more effective the earlier you get it in treatment. People who are quite ill, it can set up all sorts of problems in their body that even getting rid of the virus can't help anymore. So there's a qualifier there. The other qualifier is that it's possible that a resistance may emerge.
Okay.
And that's something that I know the CDC is very interested in, is watching very closely. That could have recommendations for treatment that change, could change recommendations for treatment. So we are starting off with some, a little bit of good news there, but it's going to depend on how this whole thing unfolds.
Thank you. Thank you.
Thank you. The gentleman from Iowa, Mr. Braley.
Thank you, Mr. Chairman. I want to thank all the witnesses for being here, but Dr. Schuchat, I want to start with you and follow up on your answer to Mr. Blunt's question about the reality of this virus and its impact on our food supply. You said there's no evidence that swine in the United States have this virus, which is a standard answer on the CDC website in response to concerns about food safety issues. And if you go to the CDC website, there's a specific question: can people catch swine flu from eating pork? And the answer says there's no evidence that swine influenza can be transmitted through food. And yet your website is the only website of all the organizations here, including the WHO, that continues to identify this as swine flu. And on the website, it also makes reference to the fact that this is a new strain of flu that consists of a mixture of genetic material from swine, avian, and human influenza viruses. I come from a state that is a leading pork producer in this country and in the world, and this outcry over the alleged connection between food safety and this virus is having an enormous economic impact on pork producers in Iowa, North Carolina, and all over this country. So is there a plan to change the website and refer to this by its appropriate scientific name, influenza A, substrain H1N1?
Our new information will have the new terminology. Our communication teams are focusing on critical information for healthcare providers, for families, and so forth. And so we do intend to make sure that the many, many thousands of website pages that we have already put up in the past week become amended, but the critical focus of the people in place right now is developing the new information that people need.
No,
so we understand the concerns and are very mindful in our communication going forward, and really need to, people are working 24 hours a day. There are communication experts in there. It's really, I don't want to be impolite, but I want to just say that our priorities are the public health information being out there quickly and accurately, and going forward we will do the best that we can.
And I appreciate that. No one appreciates that more than I do, but I'm also concerned because I was at the congressional briefing yesterday, and when you go to the CDC's website, what you find is a page, the first page that says swine influenza. And on that page, there are probably at least 10 references to swine influenza. And when your agency is one of the most critical public information dispensers in the federal government, it feeds this misperception if you don't address this issue immediately. And my point is that these other agencies are not using that terminology, and it's for a reason. So I would just encourage you, knowing that you are not in charge of the communications division at CDC, to emphasize to them the importance of making that change as quickly as possible. Would you agree to do that?
We will do the best that we can.
Now, one of the other concerns I have is the impact on workplace safety, because one of the things that OSHA has done is prepared a handbook guidance on preparing workplaces for an influenza pandemic. Have any of the three of you had an opportunity to review that pamphlet to determine whether it consists of the most up-to-date information to help prepare workplace environments to deal with the potential influenza pandemic? Dr. Sharfstein?
I haven't personally looked at it, but we have an employee health part of our team on personal protective equipment, and I know they have been talking to OSHA. So the FDA part that oversees devices, because that's really what it is, the masks and that sort of thing, relates directly to OSHA. And I know that our team and the OSHA have been talking about the different authorizations that the FDA has made, how that intersects with what OSHA needs to do to protect workers.
Mr. Braley,
yes.
I think most of the elements of HHS have worked closely with OSHA, most specifically NIOSH, with the National Institutes of Occupational Safety and Health, which is part of the CDC, has been working extremely closely with OSHA to assure that we're aligning any health guidance that we're bringing forward out of our department gets accounted for in their documents. We've worked very closely with them on masks. We've worked very closely with them on a variety of things over the last 2 or 3 years. So I'd say we're lashed up pretty good with the OSHA folks vis-a-vis assuring that we have a common message and a common set of principles.
Great, thank you.
Thank you. Next is the gentlewoman from Wisconsin, Ms. Baldwin.
Thank you, Mr. Chairman. Thank you to our panel of witnesses today. I want to join in the sentiments that have been expressed by some of my colleagues about the very good job that has been done identifying and tracking this outbreak and the communications to the Congress as we are trying to learn more and work hand in hand with you and your mission. I think an outbreak like this exposes the strengths and weaknesses in our public health system. Dr. Vander Wagen, you talked about the system as a sort of people, supplies, equipment, facilities, and systems. And I have been working with a number of my colleagues on both sides of the aisle on trying to address our public health system and strengthen it in some areas where I think that there are some weaknesses. I want to probe into two of those areas. One is relating to our state labs of hygiene. And I guess I'd start with you, Dr. Schuckett, and would like to hear your feedback on how it is these days working with the states to track and monitor this disease. And I ask the question because in my examination of the issue, and this is based on a 2007 survey by the Council of State and Territorial Epidemiologists, showing that 16 states are still completely paper-based, 20 states are still using manual reporting that's web-based, and only 2 state public health laboratories in the country have bidirectional data flow that can both send and receive laboratory messages. I understand also that technology is not yet deployed that would support new pathogen discovery and rapid electronic exchange of public health information, national bacterial and viral databases for DNA fingerprinting of infectious disease organisms, things like that. If you tell me how things are going and how those technological upgrades being deployed in our labs might help.
You know, the promise of information technology is huge, and unfortunately it hasn't gotten applied to public health infrastructure as rapidly as in some of the business community. And I think we are not where we would like to be in that area. We're, during this investigation, we've just yesterday, I think, got electronic reporting from the states coming in, which was exciting for us because it's been a long time coming. But that's just for this investigation, not for everything. You know, there are huge opportunities in that to really increase the efficiency of how public health works.
And ma'am, I would, the comments I made to the member from California apply here as well, that as we think about health reform and we think about preparedness, it's not just a matter of hospital services concerns here. I think these issues are going to need to be thought through as part of that context as well.
Yeah, let me follow up with some of the personnel challenges we're dealing with. Certainly, as states and local governments have real budget squeezes, I know that they've had to shift around staff in order to deal with this outbreak. I don't have a specific question right now on the staffing of labs of public hygiene. As I said, I'm working on bipartisan legislation. We've introduced a bill called Strengthening America's Public Health Systems Act, which deals with the technology and the personnel there. But I want to focus quickly on another area of personnel, workforce shortage, both present and looming, and that's with regard to public health veterinarians. While we have probably, I want to say about 85,000 veterinarians in the nation, I think my figures say only a little over 4,000 are food animal predominant, some with a mixed practice. The number of veterans in public, corporate, or federal positions, which includes teaching, research, military inspection, and food safety, is just under 15,000. And the projections are that we will have a significant increase in demand as we move forward for these professionals, and a significant shortfall now and as we move forward. Dr. Van der Wegen, can you talk to us a little bit about the role of public health veterinarians in with regard to this outbreak? And are you seeing that the shortage of public health veterinarians in the U.S. and around the world is having an impact now?
Yes, ma'am, and you read my eyes. My dad was the chief veterinarian for the state of California, and so I grew up in a home with a public health veterinarian, large animal practitioner to start. I think it's critically important that we think in terms of one medicine. There are many more species with health issues than humans, and even though we focus heavily on humans, and I think appropriately so, it's our species, notwithstanding that, we're at extreme risk from a variety of diseases that emerge from the animal environment. And without the kind of knowledge that public health veterinarians bring with regards to animal-based diseases that have zoonotic, that is, transmissibility from animals to humans as an underlying principle, we end up flying blind on a significant number of challenges that our health security may be confronting. So I think it's critically important that we think about that workforce and that we embrace the notion that there's more to health than simply that of humans alone.
Thank you. The gentlewoman from the Virgin Islands, Ms. Christensen.
Thank you, Mr. Chairman. Dr. Van der Wegen, you can't get away from me. You noticed, right? Okay. I'll start my first question to Dr. Sharfstein. On the flu panel diagnostic tests, are those available to the territories like my own and those in the Caribbean and those in the Pacific? Do we have the assurance that we have the availability of those tests?
Sure. I'm actually going to ask Dr. Shuckett to answer that. FDA made them available to the group of labs that CDC requested.
I got it.
Which is this network. And
yes, I was just trying to verify. We have been shipping the test kits to public health laboratories that are either part of the laboratory response network or similar public health labs, and so I don't actually know. I believe it's likely, but I will need to check, and we can get you that information. The idea is that the public health laboratories be able to that have gone through the appropriate training and are part of this system be able to perform these tests.
I would suspect that ours is in Puerto Rico, but the Pacific is much more difficult.
Right, absolutely, yeah.
And they shouldn't have to go all the way to Hawaii. So that's my concern. Would you pronounce your name for me?
Shuckett.
Shuckett? Okay. So Dr. Shuckett and Dr. Van der Wegen, and you know this already, but all during my time on the Committee on Homeland Security, I have been concerned about the inequities and the deficiencies in the public health system in certain parts of our country, communities that are rural, Indian reservations, poor communities, communities of color, and they're very vulnerable, and it's often said that when the rest of America gets a cold, we get pneumonia. So my question is, knowing this, what special efforts are being made to ensure that these communities have what they need, given that their infrastructure, the poor health infrastructure in terms of hospitals have closed, less labs, less providers. What is being done to reach to these vulnerable communities?
You know, this is a huge issue in health in general. In terms
Yes.
of the new influenza virus investigation and response, one of the teams that we've stood up is a vulnerable populations team that's really trying to address the appropriate outreach and planning for communities that may be harder hit.
Well, and Ms. Christensen, it's so good to see you again, really, because I think we have a great dialogue that's important. With regards to Indian country, because you know that's...
And I see your watch and your ring. And
With regards to Indian country, at least for those Indian people that are provided service, funded or directly provided by Indian Health Service, they're on our daily policy calls, they're on our ESF8 calls on a daily basis, so that the most recent and clear communication can be transmitted through that system to people who are dependent on those health systems. The tribal leaders are actually here in town today to talk to HHS about budgetary considerations and concerns, and we will listen and respond the best we can.
Thanks, great. And Dr. Schuckett and Dr. Sharfstein, you said that this virus is a new virus, but it has genetic material from 4 known viruses, various origins. What, if anything, does this mean in terms of the severity of the illness? Predict what you would predict our possible level of prior immunity and the development of the vaccine. Do those 4 pieces of genetic material make any difference, make it any easier to deal with?
The virus is new, and we don't. Although it's H1N1, it's different from the human H1N1s that are part of seasonal flu that many of us have been exposed to or have been vaccinated against with the seasonal flu vaccine. We can't predict with certainty what this virus will do. So the 4 components only tells us really doesn't just, it just tells us it's new. There's a possibility there might be some cross protection in certain subpopulations, and it's the kind of thing we're looking into. But it's, you know, since we've tested many thousands of strains that had never seen it, it's its novelty that's the most concern.
And I agree completely. And the only thing I would add is the question has been raised whether people who got the flu vaccine this year have any extra protection against this. And I don't think that question has fully been answered. It's one of the things that the CDC is looking into. The initial tests, which test one type of immunity, did not show any cross-reactivity, but there's the potential there, and I think that's going to be an important question to answer about it. I think in general the answer is you can understand what the virus is, but to understand how it behaves, you just have to watch how it behaves. It's just hard to determine that just from the genes alone.
Okay, well, my time is up. Thank you. Thank you.
Thank you. The gentlewoman from Illinois, Ms. Schakowsky.
Thank you, Mr. Chairman. I want to add to the chorus of thanks. I think that the response has been really comprehensive, and we have on our website now a link to yours so that people can get the best and the latest information, and I think a lot of members are doing that right now. We now have in Illinois 19 suspected cases, is it? 17 probable cases in Illinois. The one school that was closed in Illinois is in my district at the Kilmer School. I don't know if any of those have been confirmed. Do you know that? Does anybody know?
No, I don't have the details of that, and I certainly feel for the folks in your district who are coping with such a challenge.
Right. I wanted to I wanted to ask you about if and when we have immunizations and vaccinations for if not immunization, but vaccinations. Most states' Medicaid programs provide some coverage for adult beneficiaries in situations like this. And some states have exempted some populations from the nominal copay. Pregnant women, children. I realize that this is impacting a somewhat different population. Do you think that in certain public health problems like the current one, it would be good policy to exempt all Medicaid beneficiaries from cost sharing for vaccines and maybe for other things as well that are related to this outbreak? And I'm just wondering how that might impact the numbers of people who are able to access the care that they need.
Yeah, I think, and I can't answer you definitively, ma'am, but I would suggest that the considerations are that when we have this kind of an issue, it's about our population and our citizens as a whole, and less about individual benefits and services. We need to think about what can and should we do to serve our whole population. That's a little different mode than the way we think about medical care and health services in the country generally, which is about care for that one-on-one patient. Here we have to assure that our whole population is protected in the face of a challenge. Does that mean we should promote a wave policy? That's for people above my pay grade, but I think there is a real public health argument that says we have to think about population and not just think in terms of limited individual benefits, which would suggest that we should cover everyone for those threats.
Individuals, however, when seeking care, think about their own situation and whether or not they're covered and whether or not they should be going to the doctor and whether they can afford to go to the doctor. And so I think we have to think about how we convey that people who may have it should seek the care that they need.
Yeah, and it's important in this kind of circumstance to eliminate the barriers to people presenting who need to be either cared for or for whom interventions would need to be initiated. It's been a challenge in a lot of infectious disease outbreaks where communities sort of go underground and don't want to, are fearful about presenting for care or what the ability to pay. So it's very difficult with infectious diseases which don't respect, what insurance card you have.
Exactly.
And I think we really want to have a public health approach that will help the communities.
What she said.
Okay. Let me ask another question. I'm wondering if someone can describe the process for data sharing between Mexico and the United States. My understanding is that we have a number of unanswered questions, whether Mexico's in the first or second wave of illness, the percentage of people dying from the flu compared to the percentage of people who are infected, et cetera.
I'm happy to say that the CDC is part of a trinational team that is on the ground in Mexico, Mexicans, U.S. workers, and Canadians who are working on the epidemiology and laboratory aspects of investigating and responding to this concern. Information is getting better now, but information in this kind of outbreak is really difficult. Even in the best of circumstances, information can be sketchy at the beginning, and we need to hone in on the details. And in particular, before you have a good laboratory test, it's hard to tell what's going on with people with pneumonia or severe respiratory illness. And so one of the goals of the trinational team is to strengthen the laboratory capacity in Mexico so they can detect this new strain right there without having to ship to the U.S. or Canada or elsewhere. So I think we are getting much better information and cooperation. I mean, the cooperation has been good, but the information quality is improving by the day.
Thank you.
And I could just add that FDA is collaborating with the FDA equivalent in Mexico around some of the recommendations that have been made in the United States that would be applicable, like what the right dose is for young children.
Thank you.
Thank you. Ms. Eshu.
Mr. Chairman, thank you for having such a timely hearing on such an important subject. I have so many things that I want to say and ask, but this is these are, first of all, thank you for the magnificent work you do in each one of your agencies. I think they're all parts of the jewels in the crown of America's health system that needs help in so many ways. But boy, do we depend on the work that's done out of these agencies. Here's my sensibility, that people are being, and it may have been said earlier by members when I wasn't here when the hearing began. American people are inundated by the glaring headlines. And as one of the staffers said behind me, that the only break that they had from swine flu was Senator Specter switching parties. So that was the news break. And now we're back to swine flu. I'm not diminishing what all of this represents, the seriousness of it, but I think that what people need to hear over and over again are the really common sense steps of responsibility that they need to exercise. Washing our hands 1,000 times a day, the coughing, the sneezing, making sure that we cover our faces. I think on this issue of air travel in the United States, I'm pretty sensitive about this. I've commuted across the country now every single weekend for 16 and a half years. And as my mother would say, I don't know who has raised some people, but they don't cover their faces when they sneeze or they cough. Now, this is voluntary for the airlines to say something, but if they can remind everyone to fasten their seatbelts in the eventuality that something can happen to us if there's a drop, I think that that should be part of the text, and that our government ask in very strong, firm tones. We don't need to pass a law on this, but I think the director or the secretary of transportation, along with health officials, should get on the phone and have a conference call with all of the airlines and say, please, we are asking you to make this public health announcement at the beginning of every flight, because the proximity of human beings, one to another on a plane, is far different. Now, I've been told that in walking down the hall, one of the house doctors was telling me that if someone coughs or sneezes, it's 6 feet. I sit pretty close to people on the plane, so do all of you. So I would ask that you do that. Get that ball rolling, and I think that that's, in terms of prevention, really important. I wanted to ask the following, and that is, in the 109th Congress, Representative Rogers of Michigan and myself introduced legislation, and we were successful in that because it became law. It was the Biodefense and Pandemic Drug Development Act. It's called BARDA, to create, you're all nodding, a new office within HHS. What's the nexus between that office, the work that it's done, and this swine flu that evidently really doesn't come from pigs?
Ma'am, I'll answer that fairly simply. I mean, BARDA has always worked across the department to assure that the NIH Discovery Research and the FDA oversight responsibilities get brought into the mix as we do advanced development. Over the last 4 years, what has happened is that BARDA, through their funding, brought us the first licensed H5N1 vaccine. Mm-hmm. They brought about the kind of vaccine production changes that Dr. Sharfstein referred to, where we have a warm base, if you will,
well,
that
that's
would
very
allow
good
us
news.
to ramp
that's
up.
Very good news. Well, the good news was that the House did, in our economic recovery package, included increased funds for this, but the Senate took them out. I don't think they're going to be feeling so good about that right now with what's going on. Maybe one of them is tuned into this hearing tonight when they're home sitting on their sofa. So let me ask this question. I've got 4 seconds left. Can you explain how the CDC and the federal government plan to administer a flu vaccine? And given that many of those who, so far, from what I've read, that are infected are children, Is this going to be performed in schools, and will it be a mandatory vaccine?
There are answers.
Maybe those decisions
there's
haven't been made
answers
yet.
to only some of those questions, but the states have been planning around countermeasure response assessments, and they've done exercise drills with seasonal flu vaccine in terms of how will they administer promptly, get the kind of information.
So you're saying they'll probably use that same model?
Correct, and they're also making sure they have ways to find out who's gotten one dose, because there's a good chance you'll need 2 doses of this. So there are state-based planning efforts around those models.
Okay. Well, again, Mr. Chairman, this is a timely hearing. I thank all of you, the great professionals, health professionals of our country, we've learned a lot today, and I think we really have to be very sensible about this as the science and the scientists and the medical community take the lead. But we just have to hammer home what people can do to be responsible all day long, every day. And I think that's going to equip them with a sense of some sense of reassurance on this. Thank you.
Thank you, Ms. Eshu. The gentlewoman from Ohio, Ms. Sutton.
Thank you, Mr. Chairman, and thank you very much for your testimony, and even more importantly for what you're doing to try and deal with this situation and keep the public safe. I come from Ohio. We have one confirmed case, and it's in my district. The case arises in a child who traveled with his family to Mexico. And the situation over spring break, and the situation is that the school has been closed, and I know that the CDC, Dr. Schuchat, recommends, the language I see here, recommends strong consideration of school closure of schools with a confirmed case or a suspected case that has been epidemiologically linked to a confirmed case. The first question I have is, why do you stop short of saying close the school?
I do think that we are evolving our guidance over time, and some things may become clearer or stronger over time. At the time of the initial drafting of guidance, there was quite a bit of debate because illness that we had been seeing was fairly mild, and there was a question of balance. I think it's in there, but we meant to have in the guidance information about the local authorities having the best information, or respecting their ability to make decisions that were either more stringent or less stringent than ours. But I do think at this point we think it's very prudent to close schools where a case has been confirmed or is highly suspect, until we have more time to understand what's going on. So we are probably a little bit more aggressive than when that was written.
Okay. And to follow up, I should say that the superintendent in the school district did close the school, so I commend him strongly for doing that. This is a case that, as I say, a child traveling with their family. There are other siblings who go to other schools who are not, exhibiting the symptoms of the swine flu. What is the recommendation there on that situation?
Right. At the present time, what we've suggested is that the intervention be targeted at the school where the child with illness is. That additionally, that gatherings associated with that facility be closed, but recognizing that there's a lot of variation in local realities. A school district in New York City is very different than a school district in a small town, and really respecting the ability of the local authorities to assess the situation and the practicality, the issues of what's possible. We really want to make sure that our interventions are not having more adverse impact than the virus itself, but we also are being mindful that we don't know as much as we want to know so far about this particular virus, and we're probably being more aggressive than others would think we should be in order to protect people.
And isn't it correct that unless a person is exhibiting the symptoms themselves, they are, the danger of transmission is not present?
Unfortunately, there are no absolutes. And what we think about from seasonal flu is that you may be able to spread infection a day before you have symptoms yourself. Okay. And so, it's one of those circumstances where we wish it were simple, and we wish there was a very specific symptom, and we wish that everyone who is infectious knows they're infectious and can stop from spreading to others. But we're at early days with this virus. It's a new one, and we don't know whether it will be most infectious later on in illness or what. With the SARS epidemic, we were really fortunate, actually, that most of the spread occurred when people were really, really sick, not in those early days. But when you have infections that are transmissible before they're symptomatic, before a person's symptomatic, those are really tricky. And that's the case with measles, in fact. People think that if I don't vaccinate my child, it's okay, and my child can't spread the infection to somebody else. I'll know when they're sick and keep them home. But you can actually spread measles before you even know you have it. Mm-hmm. So this is just one of those challenges with infectious diseases, and why we're being pretty aggressive in our interventions now.
Okay, and if I could, this goes back to a lot of what we've heard here about common sense, about people staying home when they're sick and the like. But the people I represent, they're hardworking people, and they don't stay at home with a sneeze, because you just it's very difficult. But could you just explain and stress the importance of people who aren't feeling well staying home, their kids staying home, and frankly, the implications to employers too, and why it's to their benefit that obviously those folks stay home.
Some of the interventions that we're recommending are inconvenient. We actually did an effort in our planning a couple years ago to address the public. We did public engagement in several communities to understand what people, average citizens, were willing to do if there were risks of something like a pandemic happening. What was the trade-off in terms of personal flexibilities and then the social protections? And through that, we learned that there was support for many more aspects, I think, of this community mitigation strategy than I think some of us would have expected. And but there's a balance, and we'd really like to understand what is the severity, what is likely to be happening before we really reduce people's lives.
Thank you. I appreciate it.
Thank you. This completes our questioning, but I just really want to thank you again for being here. I thought it was very helpful to us. You heard several members say that they'd like you to keep in touch with us, but certainly I'll express that as well. Hopefully, things do not, really get to the pandemic stage, but obviously if we might at some point ask you to come back again. I hope that's not necessary. We also have a policy where probably within the next 10 days you could get additional questions from members to answer in writing, and so we'd appreciate a response. But again, thank you very much, and Godspeed in what you're doing. And without further objection, the subcommittee hearing is adjourned. Thank you.